Welcome to Discover Health, a White Mountain perspective. I'm your host, Dr. Tom Barela. We have a special program today, a program that hopefully won't put you to sleep. Our guest today is Dr. Snoring Galhotra, a pulmonologist up here at Summit Healthcare, and also the director of the sleep lab up here in Sholo. Welcome, Dr. Galhotra.
Thank you, Dr. Barela. I'm happy to be here.
Well, thank you very much, and I am delighted to talk to you today. Sleep seems to be a big issue for a lot of people. I mean, it encompasses a third of our life.
It does, yes.
And for you, it's a part of your practice up here.
It is, as you said. I'm the director of the sleep lab here at Summit Healthcare. I'm board certified in sleep medicine, pulmonary medicine, critical care medicine as well, but of course we'll talk about sleep mostly today. Yes, sleep is very important. It's a very important function for just about all the animal species that have ever been studied, whose sleep has been studied. In fact, jellyfishes even need sleep and have a sleep state, it turns out. There was an article published recently in the journal Nature that shows that. So it's a very important function, and we need to make sure we get good sleep and maintain that throughout our lives.
So it's a functional aspect of living.
Absolutely.
A functional aspect of living. And we're going to talk a little bit today about some abnormal issues in functional living. And I really don't want to talk about all the advertisements on TV for good beds and stuff like that. But that is also an important part of sleep for people who don't have any medical problems associated with it.
Well, there are plenty of advertisements on television, etc., having to do with beds and pillows to help you sleep better. And perhaps they help a little bit on the margin. But usually what our issues are is sleep hygiene. That is how we prepare ourselves for sleep, the sleep rituals that we do, the rituals that we do to get ourselves to sleep. Unfortunately, in the 20th and the 21st century, with the introduction of electricity and lighting, artificial lighting, light encroaches on our ability to sleep. You really shouldn't be looking at your iPhone or iPad well into the night, or even the television, because the normal functioning of the pineal gland, which controls it puts out the signal to help you sleep, is taken away. So there's a lot of sleep hygiene that we don't really understand or practice in the Western world. We watch television in bed, we do all these other electronic devices in bed, and sometimes people eat in bed. So you end up mixing this, what should be appropriate to do in bed with what you should be doing in the daytime. So sleep hygiene per se can lead to quite a bit of sleep restriction, in other words, insufficient sleep time, and that itself can cause problems.
I like the term sleep hygiene. People don't think about that as a hygiene issue, and we need to probably talk to those of the people that are listening about teenagers and taking their iPhones to bed at night.
Yeah, absolutely.
But let's kind of start discussion today by going through sleep as we age.
Sure,
I know it changes in young children versus us middle-aged people and then as we get older.
Yes, we have a slide here on normal sleep. The labels have gotten messed up somehow, but the blue section on each of these pies is rapid eye movement sleep, which is dream sleep. The orange section is non-REM sleep. That's how we categorize in the sleep lab the stages of sleep. And then we have awake stage. So for an infant, for a little baby, they have equal proportions almost of the REM sleep, non-REM sleep, and awake sleep. I mean, babies will sleep as much as 20 hours, as you know, Dr. Barela, as a pediatrician, and that's normal. Now, as we get older, as we become adults, the amount of REM sleep, the blue sleep there, goes down a little bit. The non-REM sleep also goes down, and then the awake time goes up to about a third of our total time. And then as we get older, the REM sleep is sort of fractured throughout the night, and we're awake a little bit more. That's the normal pattern of sleep as we age.
And that's normal. I think it's normal for people to know that when they sleep at night as we get older, that you can wake up in the middle of the night and you're still normal.
Correct.
So I can watch that 2 o'clock in the morning infomercial in the middle of the night, which actually would be bad because it's that artificial lighting that would inhibit me going back to sleep. Well, I know we get, as we get older, we also have problems with sleep as we get older, and I know you brought a slide in here that talks about sleep problems as we get older, and we want to talk about those in a little bit more depth.
Sure.
It looks like
the next slide talks about how we can have different types of issues as we age. We have insomnia, which is difficulty falling asleep or staying asleep. And at age 55, something like 49% of people will have that issue at some point in their life, at some point during the year. And then age 65 and then age 75 are the next two. So insomnia itself is actually the biggest, the most common sleep problems that we have. And then snoring, we tend to snore as well in our 50s, and then it gets a little bit less later on. I'm not sure why that is, so I won't speculate. But sleep apnea, which means quitting breathing during sleep, is pretty constant throughout the 50s, 60s, and 70s, and we'll talk a lot more about that later.
Because that's a bigger problem up here. A big problem for us on the mountain, as it is everywhere, but maybe some exacerbations special on the mountain.
Correct.
And then we have restless leg syndrome, which is...
Restless leg syndrome is defined as the tendency to want to move your legs when you're sitting still, and there are various causes of that, and that's also increases as we get older.
And there really are two types of sleep disorders. And I know you talk about parasomnias is really one of the classes that is out there.
Right. Parasomnias is a big term, is a term for any sort of unusual behavior during sleep, like walking, sleepwalking, talking in your sleep, or even eating, going to the refrigerator and making yourself a sandwich. And then there's something called a REM behavior disorder, where you're very active during dream sleep and you act out your dreams. And that's clearly a parasomnia that can sometimes be quite dangerous, not only to the person, but also to their spouse or bed partner.
And that is really a broad topic that we really don't want to focus on today. We probably could have a couple shows on that itself.
We could.
So let's go on and get to the crux of the matter today, which is dysomnias.
So dysomnia is defined rather broadly. It's where your sleep, when you do sleep, can be pretty normal. But patients can either sleep too long, too little, or sleep at the wrong time. So it's a problem with the quantity of sleep and the timing, and that can affect your life. It can, if you are asleep into the early morning, or excuse me, mid-morning, and you have to be at work, that can cause problems with your life. Sleep apnea is one of the dysomnias, and it's actually a very important one. And it can be affected by all sorts of things, medications that we use, the shape of our body. And then there are two different types of sleep apnea. There's obstructive sleep apnea, which means that the throat closes up intermittently throughout the night. And the other one is called central sleep apnea, and there are a few different causes of that. And we see quite a bit of both up here on the mountain.
So when people come to you as a sleep specialist, what usually brings them to you?
Usually it's their spouse. Usually if the husband is snoring and chortling during the night, choking, gasping for air, quitting breathing so that the wife is elbowing him in the middle of the night to start breathing again. It's usually those sorts of symptoms, excuse me, that bring a patient in. Usually the patient who's suffering from this condition is pretty reluctant to come in. It's really their bed partner who brings them in because they're concerned about their health. The other source of referrals I have is from the patient's doctors. Often their cardiologists will send them to me because their blood pressure is sky high despite being on 3 or 4 different medicines. And that's one of the indicators that you might have sleep apnea that's not being treated.
So are there any hallmarks of telling that a person has sleep apnea? I mean,
certainly.
Okay.
The common symptoms are, excuse me, snoring. Of course, is not everybody who snores has sleep apnea, but snoring is. If you have obstructive sleep apnea, most likely you will snore. Witnessed apneas, meaning your family member has noticed that you quit breathing, which means at least 10 seconds or longer during sleep. If you make other weird noises during your sleep, if your breathing is irregular during sleep, if you have high blood pressure, as I mentioned, that's not coming into, is not being controlled properly. If you have memory issues, if you fall asleep at the wheel driving, that's a pretty strong indicator that maybe there's sleep apnea going on. So there's plenty of symptoms, and just feeling fatigued, unwell, depressed. All of these things can be due to sleep apnea.
All right, now snoring is a big issue for people. I mean,
Right.
We see TV commercials all the time for snoring aids.
Correct.
Should I buy one of those things if I'm a snorer and my spouse is giving me a hard time?
Yeah. So yes, there are plenty of excuse me, products out there to help people that claim to help people who snore. And if you have nasal congestion, and using those Breathe Right strips may actually help that. But I worry as a sleep specialist that it may just be the tip of the iceberg. It may be that you snore, but then there might also be other things going on underneath below the waterline of the iceberg. So if using the Breathe Right strip or the little oral appliances you can buy for $10 online isn't taking care of those other symptoms, then you really need medical attention.
All right. So weight, a big issue for
weight is
definitely
definitely, yes, sir. Obstructive sleep apnea is because of narrowness of the throat, and weight is very strongly correlated with that. So as as our weight increases, the amount of chubbiness, as I tell my patients, in the throat also increases, and that narrows the caliber of the throat, so it allows the throat muscles to close intermittently throughout the night, and that's what obstructive sleep apnea is. You can have obstructive sleep apnea even if you're not super chubby, like myself. I mean, I have sleep apnea. My BMI, as they call it, that's the number we use, is actually less than 25. But I just chose the wrong parents. So anatomy of my throat is such that it still collapses. Now, I've lost 30 pounds, and so the number of times I quit breathing has come down. So I will continue my quest to get down to a weight where it doesn't affect me.
Didn't mean to get personal.
No,
here,
no. I'm
but
happy
that's a
to
good
share.
point,
I'm
that
happy to share.
It can, other than having that Pickwickian with Darwin, not Darwin.
One of the 18th century
Dickens,
yes.
described. So it can be genetic too.
It can certainly be genetic. It runs in families.
And I think it's important that people understand that, you know, normally adults breathe maybe 4 to 5 times, or breathe such that there's 4 to 5 seconds between breathing.
breaths. Yeah.
But you're defining apnea as quitting breathing for over
10 seconds or longer. Yes,
okay.
sir.
So when a patient comes into your office, can you tell by looking at them
whether they have sleep apnea?
Yes.
It's by the time a patient reaches my exam room, my office, there have been plenty of indications either from the referring physician or from the patient's family members that there really is a problem. So, to be honest, I would say 95+% of the time when I see a patient and the patient comes to me to look into sleep apnea, they truly do have sleep apnea. They truly do quit breathing at night, or their brain forgets to tell their breathing muscles to work, which is the other type of sleep apnea, central sleep apnea.
A little bit.
But unfortunately, insurance plans don't go by my word. I mean, I have to actually do a sleep study on the patient to prove that they have sleep apnea, and then of course that way I can find out what sort of technology they would need, like a CPAP device or a BiPAP device, to treat their sleep apnea.
All right, so you, as you indicated in the introduction, you're director of the sleep lab. So can you tell us a little bit about what happens in making the diagnosis in your sleep lab?
Yes, indeed, I certainly can. So we have a 4-bed sleep lab. Each of the sleep beds is basically a sleep number bed, which elevates, is very comfortable. My technicians, what they do is they hook up the patient to electrodes on their head. There's a couple of wires this way to measure the excursion of the chest and the belly. There's about 16 different electrical signals that are monitored all throughout the night. Brain waves, oxygen level, flow, airflow in the nostrils, etc. So the technicians monitor that the whole night. It's all recorded. If the patient quits breathing 15 times or more, and we're talking about these 10-second pauses in breathing.
In what time span?
So within the first 2 hours of the sleep study, if they quit breathing that much, then my technicians will fit the patient with a soft mask, usually over their nose or sometimes nose and mouth, and then give them a little bit of air pressure through a little hose attached to the mask to see if that takes away those episodes of quitting breathing, those apneas. And then they will keep going up and down on the pressure, titrating the pressures to see what works best for them. And usually, I would say more than half the time, we can accomplish everything in one night, one 6-hour sleep study overnight.
So people come in 9 o'clock or 10 o'clock in the evening.
Correct.
And you hook them up with all of this stuff and you tell them, go to sleep.
Go to sleep, yes.
Yeah. with no iPad or cell phone present.
Yeah, there are TVs in the room because we're, as a nation, we have that sleep hygiene problem. So, we let them watch TV for a little bit and then turn it off and then watch them sleep.
And then hope they go to sleep, yes.
Yeah. So patients worry that one of the commonest questions I get from my patients is whom I'm going to send to the sleep lab. Well, doc, I just can't sleep in a strange environment. I can't sleep when I'm away from home. And yes, that's true. It's an artificial environment. It's a nice, comfortable bed. It looks like a motel room with a dresser and everything, nightstand. But truthfully, there's only about 1 out of 200 patients don't get any sleep, so that where I can't make a diagnosis.
So after they come out of the sleep lab and you get to see that they have a lot of
Right.
Apnea episodes,
Correct.
then
Then-
you're able to come up with,
So by the end of that split night sleep study, that 1 night study where the first half of it is the diagnostic part and the second part is the titration part, we pretty much know what sort of equipment I'm going to order for the patient. So if
Okay.
it's a CPAP machine, then my staff will call the patient and say, we're ordering this for you from one of the local companies. And then the patient uses the equipment, comes back in about 60 days to visit with me, and then we download the information from the CPAP machine and find out what they've been doing.
Whether you've made them
what
better.
Yes, exactly.
oh, that's cool.
Yeah.
So you kind of, with the increasing pressure in the mask in the sleep lab,
Right.
you've really kind of tried to mimic what CPAP might be able to do for them. So
That's-
you have a good idea of it before the patient leaves you.
Exactly.
Well, that-
Yeah. By the way, the whole idea of using air pressure to treat sleep apnea it sounds like a weird idea, but all it is the air pressure keeps the back of the throat open. It stents open those throat muscles that chubbiness or other anatomic issues have caused allowed it to close up.
Okay. So I want to switch here. Before I talk about the consequences of inappropriately treated sleep apnea, I want to give you a chance to talk about your other favorite topic, which is central sleep apnea.
Yes. So, thank you. Yeah, central sleep apnea is somewhat of a different animal than obstructive sleep apnea. Obstructive means that there's an obstruction intermittently throughout the night, whereas central sleep apnea means that the brain forgets to tell the breathing muscles to work. The effect is the same. That is, there's no oxygen coming in and the carbon dioxide isn't leaving the lungs, and so the oxygen level drops intermittently all throughout the night. When the oxygen level drops, it causes a host of consequences to the body. Increasing blood pressure because epinephrine and adrenaline and noradrenaline get secreted into the bloodstream to try to open up the airways. The heart beats faster, and that can lead to heart attacks, that can lead to strokes, that can lead to dysrhythmias like atrial fibrillation. Sleep apnea, by the way, is one of the 2 common causes of atrial fibrillation in the United States. The other one being alcohol consumption, excessive alcohol consumption.
And those, of course, are abnormal beating of the heart,
Right.
which
Can then lead to
is
more
serious.
heart consequences. Yeah. So back to central sleep apnea, it's sort of a chicken or the egg question, kind of a conundrum. If you have obstructive sleep apnea and you don't treat it, you can end up with heart failure. If you have heart failure, you can end up with central sleep apnea also. The other population of patients that have central sleep apnea are the ones who are using opioids. Now, in this country, we have an opioid crisis. We're well aware of that, and this community certainly shares that problem. So when you're on OxyContin or any of those opioids, morphine, etc., it suppresses the brain stem, the part of the brain stem that controls breathing during sleep. And so you end up with central sleep apnea on that basis. And the third cause of central sleep apnea here in our community is the altitude. There is something called high altitude periodic ventilation. Essentially, it's central sleep apnea. So in our sleep lab, I would say 30% of patients at least 30% of patients have central sleep apnea as an important part of their disease.
So can you diagnose the central sleep apnea versus obstructive sleep apnea?
Absolutely, we can. Yeah, we have the technology to be able to tell what's an obstructive apnea versus a central apnea, and then the treatment is a little bit more complicated than just CPAP. The CPAP means continuous positive airway pressure. Then there's BiPAP, which means 2 different pressures. A pressure when you breathe in and a somewhat lower pressure when you breathe out. And then there's even more sophisticated technology where the machine will give you a breath if your brain forgets to tell you to breathe. And that's, I'm using more and more of that technology to help patients up here.
So BiPAP really is a real advance for being able to treat central.
Yes.
Because I remember years ago, the only way we could treat central sleep apnea was to put them actually on ventilators and
Correct,
put them on
correct.
tracheostomies and stuff like that.
True. So now we have something called BiPAP Auto SV, which allows you to do the same thing but with a mask rather than a tracheotomy.
Wow, that is really something.
Yeah.
Well, one of the other issues is we're a little bit at high altitude up here, and so how does that affect the potential consequences of undiagnosed sleep apnea?
Well, at sea level or at the altitude in Phoenix, which is between 1,200 to 1,400 feet, the excursion, the drop in the oxygen level overnight related to sleep apnea is not as bad as it is up here, simply because we're at higher altitude, the air is thinner, there's less oxygen up here. So in that sense, our altitude of 6,500 feet or higher is a challenge, is more of a threat to people who have untreated sleep apnea. I have a few patients who live in the Phoenix area and live here 6 months of the year, and whatever sleep studies they get done in Phoenix tend to show only mild sleep apnea, but when they come up here they have a lot more trouble. And so when I send them to the sleep lab, I find that they also have central sleep apnea.
Impressive.
Yeah.
So the most serious consequence of untreated sleep apnea, in other words, people have it, they don't recognize
Correct.
it, is?
Well, the chance of a stroke or a heart attack is 4 to 10 times higher in people who have sleep apnea and don't have it treated.
So stroke, heart
disease, heart attack, yeah.
From hypertension and also not getting enough oxygen to the heart?
Correct.
Not sleeping well?
Not sleeping
having
well.
difficulties during the daytime?
Increased chance of accidents. Serious accidents are certainly correlated with untreated sleep apnea.
You know, we're at the end of our time. And
I
wish I had more time to talk about this. And I'm going to thank you very much for taking time out of your busy schedule to spend a day with us. And this is Dr. Galhotra, the director of the sleep lab at Summit Healthcare. We thank you for watching, and if you have sleep problems or snore a lot, now you know where to go. Thank you.